great.
Describing the typical purpose with your cells.
Can you hear that?
Oh, whoa. Hi, Dr. Lee.
Hi.
How you doing?
Yeah, very good, Miss John.
Oh, good. That's a big auditorium.
Yes, yes.
You're working, that's in Arkansas, right?
Yes, yes. I stay in Arkansas. Yeah.
Wow. That must have been really, how long you been there? How long you lived there?
I already been here more than 3 years.
Oh, okay.
Yeah.
Do you like spare ribs? Spare ribs?
Oh, oh yes, yes. Here I have a very good, excellent surgery.
I know. Yeah, Arkansas has good ribs, right?
Yes, yes.
They're known for that, I think.
Oh yes, very sweet.
Yeah. Did you have those in China too? The same thing?
Yeah, I think so.
Same thing?
Yeah.
Very good. Yeah, I want to get together with you one of these days, and I'll get a hold of you. And can you write your email again? I'm very bad. Just put it in the chat. Okay.
Okay. Okay.
Do you use medtion.com? Medtion.com?
I use Outlook.
Oh yeah, I want to learn all that. I want to learn all that because I would like to televise more to China. We have Dr. Ben doing UHAs. Oh, there you go. There's you go. Okay. Okay.
Okay.
Hey, Ahmad, how you doing?
Very well. How about you?
Good. Good. I'll be with you in a few minutes.
Okay. No rush.
All right. Okay, we got about 10 minutes. Hello, Dr. Hall.
Hi, Dr. Bennett. How are you?
You're a good student. You're ahead of time.
Yeah. My alarm kicks me off at 10 minutes before, so I join in.
You're in Miami, right?
Yeah, mostly
okay.
in Fort Lauderdale, though.
Oh, okay. Yeah, I'm down on the beach, Miami Beach.
Yeah. The beach has been crazy this week.
Yeah, well, you know, I live on the other side of South Beach, so I really don't see what's going on. It's quiet over here, but I guess over there it's a zoo.
Yeah.
And everywhere's packed. People really aren't listening to the advisories.
Nope. They think the pandemic is over. They think it's over already.
Yeah, the good news is gone. Hi, Dr. Krisht. You're muted. You're muted. Can't hear you, Dr. Krisht. There you go. You're not muted now. There you go. How you been?
Good, good. How are you?
Good, good.
Yeah.
Been busy?
Yeah, the usual.
Yeah. No courses this week?
No.
You guys have a lot of courses, right?
Yeah, there's a good number coming up. So there's one next week with the WFNS. I don't know if you're hosting this or not.
Okay, which one is that? And a couple of them. Endoscopy one, neuroendoscopy.
This is it's a 2-day with the WFNS and honoring Professor Yazergil.
I'd like to. If I'm not, I'm probably am. I'm doing a lot.
Yeah.
Getting confused sometimes.
Yeah, and we got one with the one that is Dr. Al-Mafti series in April.
Oh, okay.
Dr. Burba.
Okay.
They have it running now, actually, around today.
Yeah. Right now, actually, it was a little late. About 8 minutes ago live.
That's right.
Yeah, they're a little late. They had a couple weeks off. Now they're starting back, and they have like I think 4 or 5 more. It's on robotics today. Robotics and neurosurgery.
I see.
Okay, excuse me for a minute. Gotta get rid of that one.
Professor Kadri, how are you? You are muted.
You're muted, Doctor. I think he's talking, thinks he's unmuted. Hi, Dr. Kadri, how you doing? Okay, well, Pin.
He's far away in Brazil. He can't hear us.
Oh, yeah, you gotta yell. Okay, Dr. Lee is here. We're just waiting for we have about 4 minutes. Wait for Dr. Lawton. Right, Ahmad, then we can start once Dr. Lawton comes.
Yes, when we see also
Okay.
Professor Lawton on.
Hey, John.
Yes.
Yeah, during the session, usually how many attendees are on the YouTube channel instead of the Zoom?
It's hard to say. It's hard to say exactly people, because a lot of people just, I don't think they register. And they have analytic programs that can measure that, but they're kind of complicated. I don't know how to run them. I got a basic overview of some programs, but it's very inaccurate. It gives you a general idea, but not too accurate. I just don't know enough about statistics and programs.
It seems like the videos show better on YouTube than Zoom.
Yeah. You mean visually they look better?
Yeah, they don't have the interruptions.
The quality, yeah. Well, we use both. So I put the Zoom one actually on the website, and the YouTube is on the YouTube. Obviously, I hook it up to that. Have you talked to Mike recently?
He's on.
Oh, okay.
Yeah, I see.
There he is.
I see Mike, yeah.
Hey, John. How are you?
Hey, Mike, welcome.
Yeah,
Hey,
How you
Michael.
doing?
I'm good. What's going on?
You ready to roll?
Ready when you are.
Okay, let's go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening. This is Dr. John Bennett from Miami Beach, televising on neurosurgical.tv. We're broadcasting a series of Achieving Mastery in Aneurysm Microneurosurgery with Dr. Ali Krisht and Dr. Lawton. And it's being translated into Chinese by Dr. Lee. And we'd like to welcome especially the Chinese audience. And we'll turn it right over to Ali. Go ahead, Ali. It's all yours.
Thank you, John. Thank you, everyone, for those who came back and for those who just joined us. This is a series that this is our fourth session, myself and Dr. Lawton, Michael, on the different types of aneurysms. And today's discussion on Paraklinoid aneurysms. It's one of those aneurysms that has for a longer time been a challenge for neurosurgeons, and I think nowadays it's kind of been unlocked, and it's one of the more fun aneurysms to clip in a way. And today we'll be going over our perspectives of how to approach it, myself and Michael. So without taking much time, I'll let Michael start. And again, like I mentioned before, he doesn't need much introduction. Michael? You're
Can you hear me?
muted. Okay, now we can hear you.
Okay, good. Good to see you, Ali. You look like you're doing well. It's not really dark there in Arkansas, is it?
Just barely that.
All right, let me go ahead and share my screen. All right, do you see my title slide?
Yes.
Okay, and is it presenter view or just the title?
Well, it looks good, whichever it is.
Okay. Well, so today we're going to talk about ophthalmic and paraklinoid aneurysms. And as just by way of introduction, you know, I think these are one of the more complicated aneurysms to learn. They're not like the other aneurysms that we've been talking about that just sit there in the subarachnoid space. They're deeply embedded into this little triangular pocket of anatomy. And it's really, I think, a challenge to learn the anatomy and to deal with aneurysms in this region because you lose certain key things like proximal control and visualization and maneuverability. So it's definitely a step up in degree of difficulty. So these are just some initial slides to get everybody on the same page. Here you can see the normal ophthalmic artery anatomy. You see that it's the first branch off of the the ophthalmic segment of the carotid artery. Just as it goes past the distal dural ring, the artery comes off and it rises up and bends forward into the optic canal. So this is your classic anatomy, but there's a lot of variation. These are some of the variants. Here is a ophthalmic artery that arises from the cavernous or C4 segment. You can see it really at the beginning of the siphon before it makes that turn, and it runs forward and into the cavernous sinus almost underneath the siphon. Here you can see a clinoidal origin. In other words, more proximal to the distal dural ring, where it pops through the floor of the canal and then joins the optic nerve. And here's another example of where it sort of bends around and in. So you see these variations, and not only these, but sometimes you'll see different layers of dura that invest both sides of the ophthalmic, which really confuse the anatomy. And you have to be careful because if you end up doing your ring dissection and you cut across the ophthalmic, it will be quite a surprise. These are just some nomenclature of the segments of the carotid. I like this Van Loveren classification where the C1 segment is the cervical portion. The carotid canal portion here is the C2. You've got your petroclival ligament here, which is the end of the C3 segment, the lacerum segment, very short. C4 is the cavernous, the C5 is the clinoidal, and then your supraclinoid segment is bisected by PCOM into the ophthalmic segment here and the communicating segment there. So these are part of the language of talking about these aneurysms. And what we'll be talking about primarily are those that are in the C5 and the C6 segments. So this is a really instructive slide because it shows you some of these relationships. The C5 segment, which is really at the heart of all this, is right here. And you can see here the distal dural ring. On the top of that clinoidal segment, you can see the proximal ring here on the bottom part of the segment. And between the two rings is this clinoidal segment. They're not actually rings. We talk about them as proximal and distal rings, but in fact, these are layers of dura that intersect the carotid. So until you cut them into rings, they're really layers. And these layers are on the top here and on the bottom here of the anterior clinoid process. So you really have to remove the bone in order to even begin to see the layers, and then you have to cut around them to form them into these rings that we talk about. So this gives you a nice lateral view. You can see here a posterior view, and here you can see an anterior view. So different perspectives showing this relationship. Key arteries or key branches are the ophthalmic here and the hypophyseal here, running to the pituitary stalk, and also the undersurface of the chiasm. Now, the bone is really important. This is a view of the sphenoid bone, and you can see the anterior clinoid process here. This is what we're talking about. And when you think about its attachments to the skull base, you have an attachment here on the lesser wing of the sphenoid. You have an attachment here medially where it bridges to the optic canal. And then you have the optic strut underneath here. And I'll show you these in different views. This is the view of the optic canal. So you're looking right down the barrel here. Your clinoid is over here. So here's your sphenoid ridge. Here's your bridge to the optic canal. And here's your optic strut. So you can see the 3 points of attachment, and each one of these needs to be broken in order to do your clinoidectomy. Here's a nice view of the superior orbital fissure, which runs underneath that lesser wing of the sphenoid and transmits the nerves here. And looking here at the optic strut, this is another view. We're looking kind of in line with the optic nerve, and you can see this bridge of bone that buttresses the optic or the anterior clinoid from underneath. So really important to always visualize those 3 bony attachments and think about those as you're breaking the clinoid free. Here's a classic Lawton picture. You can see the clinoid bone here in situ. You can see the superior orbital fissure here, the optic canal here, and some of those points of adhesion that we've been talking about. And you can also see the layers as they sweep off of the clinoid and course towards the carotid. Here, after all of that's been done, you can see the bone removal, you can see the layers, the incision of the layers, and then the formation of the rings. Here, the distal dural ring here the proximal dural ring. So clinoidectomy can be done obviously extradurally or intradurally. These illustrations show the intradural clinoidectomy. I have generally favored the intradural approach just because not every ophthalmic or not every aneurysm needs a clinoidectomy. And when you get intradural, you can assess whether or not it's necessary. And so you save yourself a lot of unnecessary clinoidectomy if you do these intradurally. On the flip side, if you do them extradurally, it's a lot cleaner. You know, you just get the work done up front. Extradurally, the dura provides a protective layer, keeps any venous blood or bone dust off of the optic nerve and the other structures. So it is cleaner, but again, the trade-off is that you're not always certain that you need it. And also, there is some issue if the clinoid is really close to the aneurysm and you have some risk of rupturing the aneurysm by doing your clinoidectomy, then in those cases, if it happens extradurally before you've had a chance to really get intradural and to explore everything, you can really be caught behind the 8 ball if that were to happen. So in general, I prefer now the extradural clinoidectomies when there really isn't that intimate relationship with the aneurysm, and I know that the clinoid removal is going to be absolutely necessary. So in those cases, I now prefer the extradural. Here are the steps. This is the dural incision along the lesser wing of the sphenoid and then across the canal over to the medial aspect. You can flap these dural leaflets to expose the bone. I like to do the optic canal unroofing initially because that way you give breathing room to the optic nerve, and any kind of pressure or manipulation on the tissue, which I try to minimize, but any pressure that is there, you've created space for it to tolerate it. So do that first. It's also a great landmark. You can see that lateral edge of the sheath. and that tells you the medial border of the anterior clinoid process, and you can go from there. Generally, I like to cavitate here just to debulk the bone, and then work on those points of adhesion, laterally, medially, and down here at the strut. And when you have those 3 points of attachment broken down and disassembled, then you can remove the clinoid. You're left with this prominence of the strut, and then it's just a matter of drilling further and further medially. Typically, you have to start cutting those layers. You go across the dural layer over the carotid and underneath the optic nerve. And with each snip of your scissors, you're getting further along here, and it exposes more and more of the strut. So you progressively snip and then drill and snip and drill, and you work your way all the way underneath the ophthalmic artery and into that medial space. So that's sort of the process. And you can see here at the end of it all, you can take the strut all the way down to its insertion into the sphenoid bone, and that takes you all the way into the carotid cave on the medial side. The last part is usually this lateral dissection of the ring, going around the lateral aspect and underneath. And then as you make this circle, you can meet in the middle, and this whole clinoidal segment then becomes mobile, and it can pull out of the carotid canal, and you get the mobility to visualize your anatomy and pathology. This is a great picture because it shows you the slants of the distal dural ring. Here you're looking from an endonasal perspective with the stalk here, the chiasm here, the optic nerve here. And here's the ophthalmic artery. You can see that classic course up and then into the optic canal. And from this medial perspective, you see how the dural ring just doesn't come straight around in a transverse way, but there's a slant. It's going both posteriorly and inferiorly. So you've got an angle. And so to cut back along this line, you end up working from underneath the ophthalmic in the what I call the axilla to a point here where you can go no further. And you have to then transition to what I call over the shoulder, meaning you then have to go over the ophthalmic, under the optic nerve, and continue on in this direction to continue your course, your circumference around here. So that's a real important transition that you'll see in some of these upcoming videos. Now, the clipping, you know, Art Day always used to say there's one perfect clip for every aneurysm, and for the ophthalmic, I think this side curved or side angle clip is that one perfect clip. It gives you a line of the blade that's more parallel with the carotid. It's not perfectly parallel, but by bending the blade backwards, it gives you that angle. For larger aneurysms, you can use a tandem clip construct that allows you to reconstruct the origin of the ophthalmic when it comes from the base like this. And then, of course, for more medially projecting aneurysms like the classic superior hypophyseal artery aneurysm or a clinoidal segment aneurysm that's pointing medially, these encircling or fenestrated clips, right angle fenestrated clips, are the clip of choice for that. These are some of these constructs using fenestrated clips. You have the tandem clips, which are basically a stack, which I like to place from proximal on the neck to distal on the neck. So you go toe to heel, you overlap the metal with the toe underlapping the heel, and you just keep working your way back until you reach the end. Being really careful in this space here to take care of the PCOM and the enterocroidal artery and any other hypophyseal branches that are coming off. Other variations, these are the counter clipping facing clips where you have two fenestrated clips in opposite direction, but here they're facing one another. Here's a counter clipping technique, but they're crosswise, meaning you're going heel to heel with the blades going in opposite directions. So a lot of different ways to do this. This is a nice clean way to march from one end to the other. This is a nice way when you don't have a lot of space to work your clips in, and you just have this central region, almost like a T-bar clip. Anyway, you can build these in a variety of different ways. Now, it seems everybody has their own way of thinking about the variations of paraclinoid aneurysms. This is mine. The most common ones are going to be your ophthalmic and your hypophyseal right here in the middle. If you go distally, you're going to have your dorsal carotid on this superior wall of the carotid. You're going to have your ventral carotid or ventral wall aneurysm on the inferior wall. And then, of course, PCOM. So these are all anterior or proximal to PCOM. Now, if you go in the other direction more proximally, you're going to have your clinoidal segment aneurysms that are between the rings. And you've got this cave aneurysm in that medial pocket down in here. So these are basically 6 different variations. These will account for most of what you'll see. But just as an example, you know, the clinoidal segment aneurysms come in a variety of different shapes and sizes. You can have those that project laterally. We did one this week that projected upwards laterally into the clinoid bone. You can have them project in the clinoidal segment downward into the cavernous sinus, and you can have them project medially into that carotid cave space. So a lot of variations, even within this pretty basic classification of 6 types. So I'm going to show you just a couple of cases. These are simple cases, and they're not meant to be, you know, the biggest and baddest case. These are just to show some of these concepts. So here you can see
its slight medial projection.
You can see the aneurysm, a very simple one. There's nothing very complicated about the clinoid bone. I always look for pneumatization because that's a factor that will affect your closure. And this is just a standard pterional incision and pterional craniotomy approach. Some of the anatomy we've talked about. And here is the extradural plynodectomy. You can see here removal of the bone. You can see when it comes out, you get a little bleeding from the cavernous sinus, but I like to use that as an opportunity to inject some tissile. This is my fellow doing some of the, my chief resident doing some of the drilling here. But once we have the clinoid completely taken care of, then it's time to open the dura. And I really like Ali's vertical incision here right along the sylvian fissure. You don't need much, takes you right down to the anatomy that's of interest here. And now you get right down to this region where we're going to start our ring dissection. So here is the optic nerve in this space. You can see the dura of the clinoid and the dura of the optic canal come together right there, and you can work your way into the optic canal and start dissecting that ring. Here you see our aneurysm. It's bowing the optic nerve. I like to save the arachnoid as late in the dissection as possible. But here we continue our ring dissection. This is now working our way around the lateral side of the ring. Here is the space underneath the optic nerve where the ophthalmic artery is coming off. And you can see it's a little bit lateral in its projection. Pretty nice, simple anatomy. So I'm going to use a curved clip to give a nice view down the shank. You can see the distal blade here, proximal blade here. We're going to deliberately leave a little dog ear, but we can easily address that with additional clips. So this is an intersecting curved clip. We just follow the ring out, and we slowly build this stack. And you can see that that nicely gathers in all of the aneurysm. Here's the last clip, just on that last portion of the aneurysm tissue. And the carotid artery is deep here at the tips of the blades. You can see the line of the aneurysm neck closure, and here, real nice flow in the carotid that we see on icy green. So that's just a really simple, basic clipping case. Nothing fancy, just showing the extradural plynodectomy, minimal dural opening, and a fairly simple stack clip construct. So I think the other nice thing about that is these retraction system is really just these sutures that pull back on the dura, and it's a real nice way to retract the brain. So here's our next case. This is this is a real problem. If you look at this case, what you see is the sphenoid bone here has a very large sphenoid sinus, and you can see a pneumatized optic strut. So the optic strut is this space here, and you can see that that pneumatization goes all the way up into the anterior clinoid. Here's our aneurysm over here at the blue arrow, and here is this thin eggshell of bone, and all of this, what should be solid bone of the clinoid is air. And so we're going to have to deal with that. Here's the aneurysm itself. You can see your classic superior projection of the aneurysm. But I want to show you the yo-yo technique is something that we developed to address that. So there's the incision. There is the plynodectomy that we've been talking about, and here is going to show you the intradural plynodectomy. So this is the view now, looking down into the carotid cistern. You can see that I've made those dural flaps, and here, just with a little bit of bone removal, you can see I'm already into that pneumatized strut. The bone of the clinoid is really nothing more than just this thin little eggshell layer, so it's pretty easy to do our clinoidectomy, but you can see that we've entered into this sphenoid space. So here is the ring dissection. Here's the tissue of the dural ring. And as we encircle the layer here, we're creating that dural ring with these snips going laterally. So here you see the dural ring. Here's the aneurysm coming into view. This is our distal neck right here. We're going to go across the optic nerve here to get the frontal lobe to peel back a little bit and create a little space. So here is the interoptic triangle. You can see sometimes this dissection here just elevates the frontal lobe nicely, gives you that extra visualization, that extra space. And now everything's in view. So here you can see that nice proximal neck. You create just enough room here under the optic nerve. You can see the ophthalmic artery here, and this is an example of that side angled clip. So you see how the shank gets sort of bent out of your way. The blades are not parallel to the carotid, but they're more parallel than if you had just used a straight blade. And now with the aneurysm essentially quiet, we can dissect it off of the optic nerve. You can see those last bits of adhesion. But what you notice here is the aneurysm still has some fullness to it. And even though we do our indocyanin green and we see no dye getting into the aneurysm, you'll see in just a moment how this aneurysm is still alive. This goes to show you how you need to puncture these aneurysms, and just confirming that the aneurysm is no longer filling. And with a little cautery and a stacked booster clip here, we can close that extra little bit. Sometimes the clips just need an extra squeeze to get the tissues together. So aneurysms addressed. This was just a little, we were exploring a small ACOM abnormality, but nothing there. And now how do we deal with that pneumatized strut? So we've got temporalis muscle in view. So the way we do this, you don't want to just stuff muscle into that space, because if you do, it's just going to fall into the wider region of the sphenoid. You see, that muscle can just disappear and it does nothing to form a plug. But if you've previously tied this lasso around the muscle and you pull it in the opposite direction up into the intracranial space, you see how you create this plug. This yo-yo technique is essentially pushing the muscle down and then pulling it back just as you would a yo-yo. And that creates this muscle plug that obliterates that pneumatized optic strut. So here is the illustration. You get into this reverse funnel, and what you've got to do is you've got to first get into that. Here we go. First get into that with this muscle plug with the lasso around it. And once you stuff it into that space and pull it in the opposite direction, you now have the plug that's going in the right direction. You get a nice tight seal around that. And then a little fibrin glue here secures everything. So it's a real nice way to deal with that pneumatization problem. If you don't, you're almost certainly going to get a cerebrospinal fluid leak, and your patient will come back unhappy. So, so there you go. There's the post-op views. You can see the side angle clip very nicely there, and there you have it. So let me show you one more case. We've got just a few more minutes left. This is going to be an example of a clinoidal segment aneurysm. So as we look at this CTA, these typically sit right in this anterior portion of the sella. You can see it's projecting medially and a bit downward. If you look at the axial over here, you can see how it sits right there in the sella. And so that's our challenge. These are tough because you've got to get all the way around the ring and fully dissect this anatomy. So once again, arterional incision, arterional crani. Here's our steps here. And now this is a great example of how, the aneurysm has no relation to the clinoid. So I'm going to do this extradurally. This is actually my chief resident doing the clinoidectomy. But you can see here, nice removal of the clinoid, and that exposes the optic canal. It exposes this region here, and all right, so now moving further along here, we're now on the portion of the case for the ring dissection. So this is our dissection of the ring. Now we're going over the top of the optic nerve, just once again to peel back the frontal lobes and get a little bit wider view here. And as we look at the ophthalmic segment of the carotid, we see no aneurysm. It's all buried in this medial space. So what we really have to do here is do a much more aggressive ring dissection. This is that progressive drilling of the optic strut. You can see how we just go further medially. We keep taking optic strut, and as we keep removing the bone, we get to this layer of the dural ring. This is that carotid canal portion that we can start to peel the carotid out of. Now we're going laterally around the carotid and underneath. So this is getting around the 360-degree circle of the ring dissection. And here, you notice that I'm over the shoulder of the ophthalmic artery. And here's the hypophyseal artery coming off. So we've got to be really careful of that, these little branches that nourish the nerve. And as we transition, we're going from over the shoulder of the ophthalmic to, from under the, in the axilla of the ophthalmic to over the shoulder. And so as we go over the shoulder, we get around into this medial pocket and free that artery completely. So here's our first clip going on. This is going to be an angled fenestrated clip. You can see the fenestration around the carotid. You can see the medial blade that's slid underneath the hypophyseal vessel and into this medial portion here. The lateral blade is on the lateral side here. And as we inspect, you can see that the heel of the fenestration is not fully across, so we need one more clip to stack underneath, and that completes our closure on the backside. But it's not quite right. You got to snug it a little bit further forward. You see we lift the blade and we slide it a little bit further, so we've got overlapping metal. And that takes care of the back portion of the neck. And now as we inspect, you can see a good flow of the carotid artery through the fenestrations of the clips here. Good, oops, sorry. I wanted to show you the flow on the icy green of these little vessels that supply the nerve very important to see that. And that's why it's so important to preserve that arachnoid over the optic nerve as you do this dissection. Here, just inspecting the course of the blades on that medial side. And you can see how here's the siphon, here's the clinoidal segment. You almost don't see the aneurysm at all because it projects medially. And here, this just shows you the application of the blades. So it's a tough space to expose, but you can see how that dissection takes you right there. All right, so with that, I think I'm going to go to my last slide and just give you a couple closing thoughts. You know, these paraclinoid aneurysms, as you can see, they're really challenging and they're actually a lot of fun to do. They're fun because there's endless variety. You have all different sizes and shapes. We've talked about the different classifications and different relationships to the rings. And so you really have to be on your game to really understand this. So I find these to be a lot of fun, but they're also very difficult. And I think in today's era where we have flow diversion as a pretty effective alternative to open surgical clipping, there is a real competition for this particular aneurysm. I think on our side, our biggest issue is patient vision. You know, we have such a intimate relationship of the optic nerve and the aneurysm itself that vision is at risk. We've published on this extensively, looking at our visual outcomes in over 200 patients, and there is a risk. It's varies from anywhere from a couple of percent to fairly high in the literature. Ours was around 4 and change percent risk of a visual change with these aneurysms, and it goes up with the larger, more complicated aneurysm. But that's the real risk on the surgical side. On the flow diversion side, there's the issues of anticoagulation and platelet inhibition and efficacy over time. But I think it's proven itself to be a fairly effective alternative. So it really means that we have to be on the top of our game and get the best results. I throw this graph in here. It's a little bit dated now, but you can see that over time, the numbers continue to grow, ophthalmic, hypophyseal, and clinoidectomy. This is an incredibly valuable skill to have. I view it in much the way I view Sylvian fissure splitting. It's just one of those real essentials. If you're going to do aneurysm surgery, you have to know how to split the fissure well and get into that gateway down to the circle of Willis. Well, if you're going to do proximal carotid aneurysm surgery, you have to know clinoidectomy really well and be able to do this with very little risk to vision. So that, I think, is our challenge ahead. So that's what I wanted to cover. I'm going to stop my share and turn it over to Ali.
All set, Ali?
Dr. Krisht, you are muted.
There you go.
Okay, can you see my screen now?
Yes.
Okay. All right. Well, thank you, Michael. That was a great overview about the anatomy of that region. And as Michael mentioned, this is one of those areas that you really need to be very comfortable and master the anatomy of it. And then the surgical clipping of these aneurysms becomes much easier. I'll even go one further step with a statement. These are the most easy aneurysms to clip once you master exposing them. The actual clipping step is not complex, but once the exposure is done, the real trick is how to make them ready to be clipped. And once that's achieved, that's it. Then the 90% of the battle is won in a way. I want to show this graph. I have a large number of these cases, and of the 270, now they're getting close to 280, 290 aneurysms. Look at this number. There is a good number of cases that we did not clip. And this is the most common aneurysm that I don't clip as well. There's about 15 to 20% that occur in that region that you don't have to necessarily clip, because the risk of them bleeding, especially in an older person, a medially small projecting aneurysm, I would tend to follow it. And unless they are causing problems. Now, I like to look at them for surgical purposes in 4 types. The most common are the superior and inferior type, as Michael mentioned them, the ophthalmic, which is all the true ophthalmic. These are the superior paraklinoid. And then the inferior type, which starts very adherent to the ring, the distal ring, and then they grow either posteriorly like this or medially. Now, me and Evandro, Dr. De Oliveira, we didn't believe that there is superior hypophyseal large aneurysms. They're usually small. I think those ventral ones, when they project medially, and the trick to it, if you see those perforators, the superior hypophyseal perforators, they're above it. The true superior hypophyseal is above the aneurysm on the medial side, and I'll show a picture of it. The other type is, those are the medial ones. There's 2 variants. The true superior hypophyseal that you see here, which you see a small one, and they're usually distal to the takeoff of ophthalmic, and the superior hypophyseal comes from underneath, while the more proximal one at the level of the ophthalmic artery are what's called the carotid cave aneurysms in a potential space in that region. Then there is a lateral group, and that lateral group is the type that grows at the level of the ring, and if it can grow largely intradural or largely extradural or equally, and I'll show some picture. And this can be mistaken as 2 aneurysms because the ring cuts it in half, but when you expose them, they become 1 aneurysm. And that's one way to look at it. And again, there are a lot of ways of, they were described, but Evandro, for example, wanted to only include superior and inferior. And, we all have our perception of it, but to me, the surgical steps are different for these different ones, although they're in the same region. So the most common is the type 1, which is the superior type, followed by the inferior, and then the other ones, the lateral and the medial ones. Now, Michael mentioned, his points, and I agree with him. There are cases, and I have many cases that I didn't have to do them with a lot of like extradural work, because you just have to open the falciform ligament and throw the clip. You just have a small opening. I do remove the sphenoid wing to create space, because I like he showed nicely, to open the dura very close to the aneurysm. I don't like to see the brain. It just makes a difference in the patient's condition post-op. But these are the points I kind of have an advantage of the extradural approach that I like to mention. You create a pretemporal wide view, and you have a wide corridor where you can maneuver your clips. The drilling is done outside. There's a protection. You're not in direct contact with the carotid or the brain, so there's a dural barrier. The blood is less. I hate blood in the subarachnoid space, so I like all the blood to be clean outside. In case of brain swelling, you don't have a swollen brain in your way when you're drilling extradurally. And at the same time, when you put temporary clips, if you open widely and you have a clinoidal control, and sometimes I'll show some cases, I even go to the cavernous portion and put a clip. The clips are not in the way when you are, especially when you're dealing with a large aneurysm. And this becomes also more enhanced in your mind the more experience you have. No doubt, This can be complex if you don't understand it, but it's really simple once you understand it. Just like I always say, complexity is due to ignorance and simplicity is due to knowledge. The more you know about the anatomy, the easier it becomes. Michael mentioned very nicely the different points. This is just an illustration of the surgical anatomic connections or parts of the clinoid. This is not true anatomic because this is a continuous bone, but when you remove the sphenoid wing from the orbital roof, then you're left with the optic roof and optic strut, and then this is what makes the clinoid an island. You can take it out. And try always to drill the clinoid. Don't try to remove a big clinoid. Sometimes there's a little spine that goes under the carotid. You can easily injure the carotid if you don't pay attention. So you have to understand the anatomy of the dural folds very clearly as it relates to this region, because you have to see this picture in your mind before you get in there. So when you have a view, like to me, this view, the reason I feel comfortable with the extradural approach, I never worry about the rupture of the aneurysm, although it's a good point that, like Michael said, to keep in mind, but you have to be able to see the picture that is behind it. And then when you are able to see this, then everything becomes much more under your control in a way. And that's the view you have to achieve in the majority of patients, so you have safety. So I'll take examples, go from simple to more complex one. This is a superior type. You see how it looks? Both the clinoidal and supraclinoid are under the aneurysm. When it enlarges, it looks like this. And notice here, there's like a flat part. That's where the optic nerve is. This is a little bit medially projecting. You can see the picture, how it is on this side. And in those cases, if you don't clean the ring well, it will create like a tight band around the carotid. So in the old days, and Michael can remember, those were very popular for intraoperative angiography, because there was always a concern that you either close the carotid or you leave aneurysm. And the reason for that is nobody exposed the clinoid and removed it and took the dural rings. So you have the risk of either one, either over treating or under treating. So the other variant, they can become very large, is more lateral to the optic nerve. And these patients don't have as much deficits in a way. And they get buried into the frontal lobe like this, and they get very large size sometimes. So I take an example. This is a patient presented to me with a scotoma. And so this was poking into the optic nerve. You can see how medial it is. And this is the steps. I'll do it extradural. And if you notice here, this is the carotid, this is the optic nerve, this is the orbit. And I create space by dissecting laterally towards almost to V2. So I have more space. Now this, what I'm opening here, there is a ligament that goes under the third nerve. If you open it with the knife, it is furthest away from the carotid. It's like a little tent, so you don't risk cutting the carotid. And then the beginning of the oculomotor carotid membrane on the third nerve side, this is the left side, and then you clean it, and I use it also as a window to inject into the cavernous sinus, and it goes around the carotid, which makes it dry in a way, and then you clean and prepare it for the clip. So now I have full proximal control, and then I will open the dura, and as Michael mentioned, I like to open it in a small area, going to the falciform ligament. And you can see the field is clean because I did everything extradurally. And you can see the aneurysm poking into the optic nerve. See that? And that's what was causing that spot. And this is the ophthalmic artery. You have to be careful. Sometimes it takes off from the neck. And the clipping, like you see, it's the easiest part. And once you get the proper exposure, and you can see how much space I have because I went more pretemporal in a way, and you can see how much this was poking into the nerve itself. And that's kind of the view, and the rest of the closure is a small area, and then put a piece of fat or muscle towards the side. If they get larger, believe it or not, the approach is going to be the same. This is the window after opening it. We done the work extradurally and opening along the falciform ligament. Once you get the exposure, the next thing is to open the distal control. Now, if you look here, this is supraclinoid carotid. This is the aneurysm here. This is the supraclinoid and clinoidal segment. And then the next thing is I'll open proximal sylvian fissure. I like to go to the A1 because the clips are away from where the clipping process is happening. So now you can see this is clinoidal carotid, this is supraclinoid carotid, this is the proximal neck, distal neck, and this is ophthalmic artery, and that's the optic nerve. So you can see the anatomy, all of it still and working under the brain in a way. This is the ophthalmic artery being exposed, cleaning around it very well because you want to see the course of it so it doesn't get. And like Michael said, in those cases, you have to go more distal, more medial, so you can see very well the anatomy on the other side, because a lot of these cases, they bulge on the medial side as well. Even though this is a superior type, it may have a bulge on the other type. So now you can see the optic nerve, the aneurysm, and all of it. This is the clip on the clinoidal segment. And then the next clip is going to go on the A1 segment. So this is A1. The bifurcation is at this point. And then from there on, you have good control. And one of the reasons I don't put a clip very proximal here, because there's backflow from the ophthalmic, which can sometimes make the aneurysm swell in a way. So that allows the aneurysm to be compressed. So I'm coagulating, and the next thing is to put your first clip. And I want to give a word of caution. Never try to clip a large, bulky aneurysm without temporary clips. It's a recipe for rupture. I've seen it many times, and you don't want to do that. You always collapse it and somehow control it so you can get it out of the way. The rest of it now is, reconstruction. Once you secured it, you start doing it. So you see the clipping part becomes easy once you get everything under control in a way. And this will be like, you see, I'm reconstructing it because I took everything out of the optic nerve. Now, this case used to be, I have many cases which were unfortunately coiled and they lost vision. And that is a more serious problem with coiling if it's done. With pipeline, I'm still, I see that there is reports of safety, but there is also a lot of things that are in a delayed fashion being reported. Now, sometimes the aneurysm is hugging the clinoid. It is incorporated in it. In these cases, I go more proximal for control because we used to fear those aneurysms in case something happens prematurely. You can see how proximal it is. And these correlate with the location of the ophthalmic artery. The artery itself is proximal. So in these cases, I go more, and it takes a little bit extra time, about 10-15 minutes. You can see the fourth nerve here, and I go to the Parkinson's triangle and just open it and get proximal control in the segment of the transverse or the horizontal portion of the carotid. I have done this now many, many times. Again, the idea of the cavernous sinus being this big juju that we have to be scared from, it has to go away. This is part of our area that we operate on, and we should be ready. So now I can remove the clinoid safely because I have proximal control, and I'm drilling on top of the base of the aneurysm here. That's part of the aneurysm. You'll see it when I open. So, and this is the ligament which is under the third nerve, cut tangentially under it. And you see there is like a little tent. And this allows you to very early and away from the carotid start cleaning the oculomotor carotid membrane. And then once you get it ready, you see now I have the clinoidal cavernous loop. This is fourth and third nerve. And the rest of it will be the same steps. We open the dura, clean around it. And what you'll notice now when we start opening is the aneurysm started here, and then it is, that's the ring. You see how it's incorporating part of the ring, and then the aneurysm is, that's the aneurysm coming from this part of the clinoid going this way, but buried, I'm sorry, I want to show you. And now we are mobilizing the aneurysm from the nerve. And look now, the clipping. Clipping is the easiest part because this whole buried aneurysm became very nice, widely open. You can see the clinoidal, supraclinoid, and we achieved safety at all different levels. And now you just pick and choose until you get your perfect clip. And this is the, again, the clip was in the way, the clinoidal clip, so I took it, put it in the cavernous portion, and then trying to finalize the clipping steps. Like I said, these are aneurysms which are really easy to clip once you expose them because there is no perforators around and their anatomy becomes clear once you do it. Now, they can be ventral like this when they get bigger. The trick here is you have to clean the proximal part where the ring is usually incorporated in it. And now these are the two types. This is the posteriorly projecting. If you look at it, it looks like a posterior communicating artery, but it's not. For the experienced eye, you can see the angiogram, it tells you that this patient had an AVM, as you notice in this case. And if you look at the AP, only the clinoidal segment is seen. The supraclinoid, you don't see it under the aneurysm like the ophthalmic ones because it's hiding behind it in a way, because this thing is posterior to it, like you see here. And here, don't confuse them. You see, this is, you can see the proximal part and the distal part. This is PCOM and this is the ophthalmic, the paraclinoid type. When they go medially, there's some, this is what is wrongly called the superior hypophyseal. Superior hypophyseal should not have the superior hypophyseal branches on top of it. They should be under it. And I'll show examples of it. Again, this is important to see and understand it. Now, another point which Michael mentioned, you have to be careful when you put your clip. A lot of these aneurysms span the bottom part, half of the carotid, and you don't want to include the superior hypophyseal branches. This is an example. This is left side. This is the optic nerve, ophthalmic artery, clinoidal, supraclinoid. The aneurysm is here. So now we're going to change the angle to look from left to right. And as we do that, you will see now now you'll see the perforators is here. This is the optic nerve. And this is the beauty of the pretemporal route. I'm looking from totally lateral to medial, and I'm putting the clip under the ophthalmic, under the carotid, but I can see my clip on the other side, and you can see the perforator here and the clip underneath. So I have full clipping of the aneurysm, but at the same time, under view, I saw everything. And like Michael said, in those cases, you have to clean circumferentially, but I can mobilize the whole carotid out of its gutter, and you have full control on it. This is another one. You can see it. It's the similar but larger size, more proximal, and you can see how the clinoid is going to be hiding the proximal part. And for these, the same steps. We're cleaning the carotid. We prepared it for the clip, and now we have full control. And then I will open and start dissecting the aneurysm. Again, look at this corner. When you inject, it comes usually around the carotid. So this is the aneurysm. That's what I meant by the proximal ring. The proximal part of the neck, the ring is incorporated on it. If you don't clean this, then it's not going to close. That's why in the old days, they have difficulty with those aneurysms. They needed intraoperative angiography. Now, that other side, I will always look for it. Why? Because these aneurysms can sometimes bulge on the other side. This did not. But look how much mobilization I created. So now I'm cleaning to the other side. In this case, you know, I was going out of my way to clean, and then I cut this part of the attachment, and suddenly there is some oozing or bleeding from the aneurysm, which in this case, not a big deal. You just compress the aneurysm, and I have proximal control in the clinodal segment. So I'll just put a clip and then slow it down. And many times I don't put a distal clip, and depending on the flow. But if that's the case, you have full control, it's in front of you, and still look how much brain we have, but you've got plenty of space to maneuver around. Why? Because of this route that we used pretemporally. And now the rest of it is I'm finishing my cleaning process, and now you can see it's free. And now I can put my clip, you know, directly into it and under full view. So that's why clipping those aneurysms, I have to say it again, is easy once you expose them. The real point is how to expose these aneurysms. It can be very big, but still the steps are the same. This patient had bilateral ventral aneurysms. You can see it, and we went to the right side. Same steps, the approach is the same, and we're removing the clinoid. I'll skip those. And then once you open, you can see the aneurysm, distal part, but you don't see the proximal part. It's all buried into this area. Now, this aneurysm has a medial part. You see how the optic nerve is bulging, and this is diligent exposure. Like Michael said, you need to go more medially. In these cases, you want to take the optic strut to the other side, and you have to cut the dural ring 360 degrees around it. So once we get this exposed, and now the aneurysm, I put a clip on the clinodal segment. Now, I want to make a point here. The reason I put the clip is because the ring, the dural ring attachment, if you remember, these are proximally attached to the aneurysm, is much easier to split if the aneurysm decompresses. To do that, to create that space between the residual ring and the neck of the aneurysm, you need to have the aneurysm deflated, otherwise you rupture it. That's why I put a temporary clip for the dissection of this part. You see that? I'm dissecting it. Now I'm compressing the aneurysm to away. The aneurysm is now here. See that? The aneurysm is here. And now I created that space around it. So then the next thing is to look further on the other side. You see how I mobilized the aneurysm, the carotid completely out of its gutter. There is a perforator. You saw the perforator on the other side. And you will see my clip here. The suction is pushing the perforator, so the clip does not include it. And I am seeing 360 degrees around it. You see how much you mobilize the whole complex out of its gutter. The rest of it is a reconstruction process and reinforcing with a clip and then deflating it and so on. So again, it is all about exposure, and I'll just speed it up. And this is opening the medial side, collapsing the aneurysm. You can see the reconstruction towards the end, and it is all gone. Now, when they are more medial, like in this case, the clipping is a little different, and Michael showed very nicely a case like this. In those cases, same, I do the exposure outside, and once we open and clean all the anatomy in this case, then again, all this dura in this area has to be cleaned well. Because this is medial, then like Mike said, you have to really go out of your way to go very proximal and distal to see the aneurysm totally. This is A1, and now we did the distal part, now the proximal part. You take the falciform ligament all the way proximally, and you clean the ring circumferentially. If you don't clean the ring circumferentially, you will not be able to close the clip without compromising the flow in the aneurysm, or the clip will not close and the aneurysm will still be filling. So once we get this controlled, this is a clip on the A1, and then another clip on the clinodal segment. And this is the aneurysm. You can see it all in front of you, both. And this is, in this case, there was a large PCOM. So we put another clip on PCOM. And now you can see the whole aneurysm complex from inferior to superior, and that's the carotid artery in between. And you just do your reconstruction. And in this case, a fenestrated clip is applied and deflating the aneurysm and making sure you see how the reconstruction of the artery is very nice, because you remove all the ring from around it. There is nothing left in it. And at the end, you just decompress it and you look around and make sure that nothing is included. And you can see the artery is really anatomically is reestablished, as you can see here. So they can be very large, the same. This is the case I showed you earlier. The steps are the same. Removal of the clinoid. In this case, it was, again, the dural ring has to be cleaned fully from around it. The rest of it is reconstruction. And then once you finish, you can see the reconstruction, in this case, a little bit more demanding, but you can see the artery reopen. Now, the next thing, this is a post-op, but this is the ones which I call the lateral type. The ring is sitting on the aneurysm. This is one aneurysm, but it looks like it is two. And I'll show you an example. This is how they look laterally in this case. And they can enlarge and become like this. They look like two aneurysms, but in reality, this is one aneurysm. This is an example, a case which is, look here carefully, it looks like one aneurysm, but the angiogram showed there is two, one proximal to the clinoid, one distal to the clinoid. So when we do the exposure, and then you have to clean the ring from around it. In these cases, it is advisable that you do clean get proximal control in the cavernous sinus. Now, the clinoid here is an aneurysm, but it's okay. We drill around the clinoid, the aneurysm, around the carotid, we do. Now, notice here what's happening. This is the intradural aneurysm. This is the extradural aneurysm, where the clinoid was. I am cleaning the ring to make it as one aneurysm. So the next thing is, look at that, it becomes one aneurysm. I'm cleaning the ring circumferentially. That's the part which was inside. And now you can see it is one aneurysm. You can see the difference in color. This is the clinoidal part, supraclinoid part, and then you put your clip. And this is the clinoidal supraclinoid continuity in a way. And that's how it looks once you reconstruct this. These are one aneurysm. We get proximal control in the cavernous sinus. You see how they are buried sometimes inside the clinoid process. And they could be risky if you don't, and I think Roberto Hero's reported on those cases that they can go wrong. So let me just skip here. Now, believe it or not, cavernous aneurysms, I have been pushed by Evandro. He kept saying, well, if somebody's going to stent those aneurysms, why don't you clip them? I have clipped many. When I'm opening for a ophthalmic aneurysm, it so happened there's a clinoidal seg one. But we are able to do a lot of work for these cases. This is an example of a patient who was going blind. And you can see that this lady has this aneurysm. To me, this is a clippable aneurysm because it's a true aneurysm of the cavernous sinus. And in my opinion, there are two types of aneurysms: true aneurysms of the cavernous sinus and the fusiformish-like aneurysm. This one is a true aneurysm. Now, this patient also had basilar aneurysm that you can see here, and also has and this is the basilar aneurysm and has a anterior communicating aneurysm. So anyway, this was not coilable or endovascularly treatable, so we decided to clip this. But my approach usually goes in the cavernous sinus, so we decided to go ahead and close it at the same time. So we just exposed the usual, but in this case, we open widely in the cavernous sinus. And this is the carotid in the cavernous sinus. This is the fourth nerve and third nerve here. And then sorry. So then we open here, I'll show you just, this is the supraclinoid carotid. And then in this case, we opened the neck and got proximal control. And then we removed the further distal one. And then we open, this is fourth nerve and third nerve, that's V1. We just deflated the aneurysm and then went ahead and reconstructed it. The next thing is to find the proximal part, which is the ascending part. And you notice this is it's in our mind, it's the same like clipping any other complex aneurysm, like an MCA aneurysm, if you know the anatomy. This is the proximal part of the aneurysm, I mean the carotid. And now we reconstructed it. And what we ended up doing in this case, and this is the finished part of the aneurysm, we put two clips, and the carotid goes from here coming up this way. Let me just finish it fast. This is the reconstruction. You can see it with two clips. And this patient really had full recovery. There are multiple aneurysms. These are the types that we clipped many times, but I don't find the indication for it because I think these are benign aneurysms when they are intraclinoid. Now, why I showed this, there is no limit to what we can do with microsurgery if we master the anatomy and understand it very well. And it'll be a shame because there will be a loss of opportunity for the better option in a lot of these patients. And we should pursue our attempts at keeping the best, most durable option. And like Michael said, we have to elevate our game so that we compete easily with the other options and we are in a better situation. One thing about visual complications, which he mentioned, I know we went over time, but that's essential. We had severe visual loss in 2% of patients. These were new. Moderate in loss in 3%, and improvement or no change in 95%. Now, here's one thing. I had 2 patients in the first 100 cases, and I kept wondering what could have happened. And we went to the lab and we looked for what could be the cause. And there is a direct blood supply that comes from the ophthalmic artery to the nerve. And I think we haven't been paying attention to this. What's interesting, since we found this in the lab, and I start looking for that artery, I've yet to have one single patient with any visual problem in the last 150 or 60 patients. And I think that's an important point to make, other than the fact that you have to do copious irrigation with cold irrigation and using the diamond drill. And another point that I always do also is when I'm operating in that area, once I open the dura, I cover the optic nerve. The heat generated by the microscope could be very injurious. And I always keep a cottonoid all the time covering it. You cannot underestimate anything in order to protect the vision. I feel very optimistic about it. In our unruptured group, in this case, we have a large number, about 150 or so. Notice these patients, 99% of these patients within a year, they are doing great. I think, mastering the anatomy here is going to create really a big plus for these patients. And like Michael said, this is a field that we should belong to and stay there. And you spare the patient from, the problems with anticoagulation and antiplatelet therapy, which has its own risks. In addition, there is always a risk of some of these stents closing up and causing strokes. And I have patients like that. So we have to keep those in place. So I know we went a little bit over, but these are, important aneurysms to regain back into our armamentarium, because we can do a very good job for them. All right, I'll stop here, and I think we can. Okay.
Okay,
We'll go back to Michael, if you want to put your, you come back from being mute, so Ahmad will give us a couple of questions.
Yeah, thank you very much. Actually, there are a couple of questions, but mostly answered by the talks. Maybe this is for Dr. Lawton. Any other options for proximal control than the ones that Dr. Krisht mentions for proximal control?
Well, yeah, I think they've all been mentioned. The easiest and the traditional is the cervical carotid cut down and exposure in the neck. I think the exposure of the clinoidal segment gives you proximal control in some. The exposure, as Ali showed, of the cavernous C4 segment in Parkinson's triangle is another. There are others. You could do adenosine if you needed just a short, brief window of control. There are others as well. There's been, Dr. Spetzler used to talk about a Fogarty balloon catheter in the Petrus canal that you can inflate by slipping that into Glasscock's triangle. I mean, there's lots of clever ways to get control, but I don't think you need them. I think, it's very rare. I did my first carotid cut down for control on a case 2 weeks ago, and it's been literally years since I've done that. So I think you can get it elsewhere, and you don't often need it, but there's plenty of it in these spaces that we've talked about.
Okay, thank you. Now for the medially projecting aneurysm or the superior hypophyseal, how to avoid the superior hypophyseal artery, and can we use ICG to view it after surgery? This is for Dr. Krisht.
Well, the first thing to do to find the superior hypophyseal is you have to know the anatomy of these arteries. There could be 1 or 2 or 3 of them, and the way they project, they start just distal to the dural ring. Some of them even incorporate in the dural ring, so you don't want to underestimate them. They can be that early. And the other thing is in medially projecting aneurysm, I'm calling it because I don't like to call them superior hypophyseal, because the large ones are the ones that stretch the arteries superiorly. If you have those in mind, you're going to find them, especially after you put the temporary clip and collapse the aneurysm. That's key. Why I'm saying that? Because they can be stretched and look like a fibrous band, and you may cut them and they may not even bleed initially. And then later you will realize that those were gone. So you need to look for them. And this could be one reason why we didn't have a lot of, problems with vision since we've done those, because I look for you have to know the anatomy of the blood supply of the nerves and the chiasm. They come from these, they can come directly from the ophthalmic artery like we've shown, and you don't want to underestimate any little branch to save it, because that's the only way other than the being gentle with the maneuvers, you can save the vision to the nerves. But, and again, anatomy, anatomy, anatomy.
Thank you. Maybe a couple of questions from the audience. Anybody had any additional question?
I have a question to Michael. If you can elaborate on adenosine, because that was a question last week too. I haven't, used it. Yoha used it a lot. For some reason, I feel comfortable always finding some proximal control. A couple of times I've prepared to use it, ended up not using it. Do you have any experience, comments on it?
Yeah, I use it from time to time. My biggest beef with adenosine is just that it's a very short window. It gives you 30 to 60 seconds of a cardiac pause. So it's not a real long window. I think for most of these aneurysms that we've been talking about, you need anywhere from 2 to 5 minutes to do those last few maneuvers to get the clips on. And so adenosine falls a little bit short in that time window for it. But, I think when you're in trouble and you need a little help quickly, it's a real easy thing. You just call for it and your anesthesiologist can just give it as a push. I haven't had any trouble with needing, like, for example, defibrillation to restart the heart or anything like that. I think it's been safe in my experience, but I just haven't, I don't use it routinely because it's not as good or as long lasting. I do think that, as Ali stressed, the use of temporary clips proximal to the aneurysm is much better and much more definitive. So that's the way to go, really.
Thank you. Any other questions from the audience? Okay, well.
I think that covers it well. So, all right. Well, I think just to mention, we're going to be off next week. It's spring break, so we'll be spending time with our families. And thank you for everybody who attended. And we will be seeing you the week to follow, whereby we will go over the basilar aneurysms, and then there will be one more session at the end on pericallosal and pica aneurysms. Thank you, everyone. Thanks, Michael. Thank you, John.
Thanks, everybody.
Yeah, thanks, everybody. I'd like to thank Dr. Lee, the translator for Chinese.
Oh, yeah, Kylie.
Yes.
Dr. Lee, are you there, Dr. Lee? I would like to say thank you.
Yeah. Hi,
can
everyone. I'm Kylie, and thank you for letting me translate this webinar. And there are over 1,000 audience in China. So we are all grateful for the opportunity to learn, and thank you all very much.
Thank you, Kylie.
Okay, very good. Okay, we'll see everyone in 2 weeks. Thanks, everybody.
All right, bye-bye.
Okay, thank you.
Okay, we're off the air. We stopped recording. Okay, we're still on YouTube. I gotta redo the first part. I screwed up.
Fala, Matheus!
Porra, meu amigo. Thank you.
Hello, everybody.
Hello, thank you.
Oh, let me come
thank
back.
you,
I
Abu.
did not know the whole Brazilian gang is here.
Yeah.
Thank you, Professor. Great.
We're in the chaos, but it's still happy, right?
Yeah, for sure.
Let me see who else is here. Oh, Baltazar was here too.
Yeah.
Hello, how are you all?
Baltazar, how are
Here.
you? Good to see you.
Good to see you all.
Oh, the better half of Paulo.
Hello.
Okay. Nice. Well, good to see everybody, guys. And hopefully we'll soon meet in person.
Yeah.
Thank you,
Professor. Stay very safe in Brazil, guys. Stay safe.
We'll try.
Okay. All right. Take care. Bye-bye.
Bye-bye. Bye.
Okay, guys. Have a good night.
Good night. Hey, you guys from Brazil have a webcast on now, right? Isn't the one going on now?
It's about to be done.
Oh, okay.
About to finish.
Bye, boy.
Okay, Matheus. See you soon.
See you
Let's
soon.
start our
Oh, my
courses
friend.
by the end of this year.
We are missing Little Rock, huh?
Yes, sir. Okay.
Right. Stay safe, my
Bye,
friend.
everybody. Bye.
Thank you.
Okay, thanks so much. Okay, everyone, you can stay here. I'm just going to run a segment because I screwed up at the beginning and I want to run a clip where I'm starting the program and we're going to splice it into the first part. Okay, let me get, excuse me. Yeah, let me just, 10, 9, 8, 7, 6. Good afternoon from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. We have another, the fourth in the series of Achieving Mastery in Aneurysm and Microneurosurgery with Dr. Ali Krisht and Dr. Michael Lawton. So we'll turn it right over to Ali. Thank you very much. Okay, that's the clip. What do you think? Good? Nobody wants to say. Anybody want to introduce themselves and get on in front of everyone else? It's not to embarrass you, it's just to get to know you. And you certainly don't have to. Anyways, well, let me show you guys. Let me show you guys what we have coming up. You may be interested. So, okay. This is the next one we have. It's a women's, the WFNS is having a women's webcast. The ACNS, Dr. Kato is having a webcast, and also Dr. Anila Darbar from Pakistan, she's running it. That's at 3 p.m. IST, which is 5:30 in the morning here. I got to get some rest. Okay, those are the talks. And Yuha, right after that, Yuha gives his grand rounds from China with the speaker, Professor Goel, glioma surgery. And we have another one. Then Ipcherian starts a weekend webcast from Krisht, his new location. He just started his Department of Neurosurgery, or continued it. He's trying to expand it. Anyways, he's having a weekend webinar. And then also there's a French neurosurgery grand rounds tomorrow at 6 o'clock Paris time, which is noon our time here, right after Yuha's. So we got a full schedule. And there are actually 3 webcasts simultaneously tonight. There was this one and a Brazilian one, and also one from Miami, University of Miami. So anyways, glad everyone could come and follow neurosurgical.tv. That's where all the announcements for webinars and stuff are at. Oh. Okay, adios.